Good morning, everyone. It's a pleasure to have the opportunity to speak with you today. I'd like to just begin by acknowledging and thanking Roberta and David for that important and powerful presentation. And thank you to the Minister, Minister Lake, for taking the time out of his busy schedule to join us today. As Rolando said, I'm going to give you a bit of an update of research findings from the Urban Health Research Initiative. But before I do that, I will just note that I have absolutely no conflicts to declare. I imagine some of you may be wondering, what is the Urban Health Research Initiative? What is it? It's a program of research at the British Columbia Centre for Excellence in HIV/AIDS that's primarily focused on the experiences of people who use illicit drugs and addiction more broadly, as well as infectious diseases such as HIV and hepatitis. The program is really built on a platform of 3 large prospective cohort studies that are funded by the U.S. National Institutes of Health. I'm sure many of you are familiar with VIDUS, the Vancouver Injection Drug User Study, which has been following over 1,000 HIV-negative individuals who inject drugs since 1996. This is also supported by the ARISE study, which is a study of over 800 street-involved youth who use illicit drugs and live primarily in the downtown south area. VIDUS and ARISE also has a sister study called ACCESS, which is now for over 15 years been following over 1,000 HIV-positive individuals who use illicit drugs through injection and other means. And this has really served as a platform to develop a very broad interdisciplinary program of research that includes significant qualitative and ethnographic research components, health service evaluation, all the way down to clinical and structural interventions and community-based research. We also have a very large focus on clinical training and education, as well as knowledge translation. So what I'm going to do today is just provide you some highlights from our research program, some of our recent findings, and some issues that we think are important and are worthy of our attention. I apologize for the complicated slide. I'll try and put them into plain language as I go, but really what I want to help display here is that these studies have been very instrumental in monitoring a wide variety of behaviors and health outcomes in the community. This is a slide showing you the patterns of very intensive injection drug use in the community. And what you really see there overall is a very large and significant decline in very high intensity injecting in the downtown east side from the period of 1996 to 2014. While the dark blue and gray bars show large declines in heroin and cocaine injecting, you'll see beginning in 1999 there was a very rapid escalation in crack cocaine smoking, which in recent years we found to be independently associated with HIV incidence. However, that too has declined rapidly in recent years, which we think is good news. These cohorts have also been instrumental in monitoring the incidence of hepatitis C and HIV infection in the community. And as you can see, when we look over time, there has been some very stunning declines in these particular outcomes locally. When we look at treatment outcomes in the ACCESS study, we similarly see some very impressive results. This slide, those black bars in the middle of those boxes are the median viral load among HIV-positive individuals. And as you can see, in recent years, there's been a very dramatic decline in the median viral load in these particular patients. And while many people thought that dramatically scaling up antiretroviral therapy for this population would lead to the widespread development of antiretroviral resistance, we actually found by looking at data in this study that's not the case. In fact, actually the incidence of resistance has declined over time despite the dramatic scale up of these medications. So at this point you might ask yourself, well, is progress being made? And the answer certainly is yes, in many regards. We've seen very dramatic declines in high-intensity drug use, and yes, admittedly, these have been offset by some increases in other harmful drug use behaviors, in particular a rise in crystal methamphetamine injecting among street-involved youth, but overall the pattern's encouraging. We've also seen very dramatic reductions in HIV and hepatitis C infection rates and remarkable successes in the delivery of HIV treatment. But are there remaining challenges? Well, certainly there are. And one that we think that warrants some more attention is the problem of pain among people who inject drugs, particularly as this population ages, is living longer with diseases such as HIV and hepatitis and other comorbid conditions. Pain is becoming an increasing challenge. We began hearing from people in the community about frustrations in obtaining appropriate pain management, and people were also complaining that they were resorting to managing their own pain. And so we began to look at this problem. This is led by Pauline Voon, who's a nurse working with our program. She restricted this study to 483 individuals in our cohort who reported moderate to extreme pain as measured by the EuroQol instrument. It turned out that 98% of these people said that they were self-managing their pain, and these individuals who were self-managing were more likely to be homeless, but they were also more likely in a separate part of the questionnaire to have said that they had been refused prescription medications for pain. So how did they self-manage their pain? Well, unfortunately, they're resorting to very high-risk methods. 65% said they obtained diverted prescription opioids from the street, 52% said they resort to heroin injection, and 25% said they simply obtain prescription opioids from friends. We decided to look a little bit further into this issue of the denial of prescription analgesia to people who use drugs, and we found again that among people with moderate to extreme pain, 66% said they had been denied pain medication, and the primary reason in their view was that they were being accused of drug seeking. Again, the primary responses after being denied was to resort to very high-risk methods, such as buying medications off the street and injecting heroin. We felt that this issue of non-medical prescription opioid use is certainly a serious one, and one that's associated with a very large overdose epidemic throughout North America. But we also think it has very important links to the management of pain among individuals. And our point is not in making a call for priority action to blame healthcare providers for this problem, because really it's very clear. There is a complete lack of evidence-based guidelines for pain management among such high-risk individuals, as well as a glaring lack of education for practitioners in the area of pain and addiction medicine, and we could do so much better. If we really want to optimize health outcomes for people who use drugs, I think we have to move beyond simply accepting that hospitals are places where we provide life-saving treatment and care, and ask ourselves, are there something about the way hospitals are organized or structured that could some way also condition risk for people who use illicit drugs? And so we have started to turn our attention to experiences with hospital care among our cohort participants. For this study, we linked our cohorts to the St. Paul's Hospital admissions and discharges database. So we were able, through a linkage using personal health numbers, to look exactly when people were admitted, when they were discharged, and why. Between September 2005 and July 2011, we identified almost 500 individuals who had been hospitalized at least once. But what was really shocking to us was to learn that 43% of these individuals left hospital against medical advice and prematurely. These individuals tended to be younger, people who injected heroin daily or more often, and also those who had recently been incarcerated. This led us to follow this study up with an in-depth targeted qualitative study where we identified individuals in our cohort who had been identified as leaving hospital against medical advice, to really ask them what was going on for you when you left hospital against medical advice. And they told us that there was a variety of reasons, including those at the individual level, such as problems with pain management, drug withdrawal, and undertreated addiction. But there were also some social and structural conditions operating in hospitals that made people want to leave. These included abstinence-only drug policies, harassment from security guards, and a lack of access to sterile syringes. We also looked at the issue of drug use within hospital settings, because we began to hear that this is often what people were resorting to when they felt that their pain was not being appropriately managed. And in this study, we found that 43% of individuals said, yes, I actually used illicit drugs while I was hospitalized. And 48% of these individuals reported being denied pain medication while in hospital. When we looked at the relationship between these two variables, we found that those who were denied pain medications were almost 1.5 times more likely to use drugs while they were in hospital. So I think this raises an interesting question, and it's, does the principle of equivalence apply to hospitals? Well, the principle of equivalence is usually applied to discussions about prisons, and it asserts that really, although prisoners lose certain rights and freedoms, such as the freedom to free movement, they are entitled to equivalent care to what is provided in the community. But I find it interesting that we're not having the same discussion about hospitals, because clearly at this point in our development, we're not offering the same services to people who use drugs in hospitals that are available in the community. And it raises a second question: is there a role for harm reduction within hospital settings? We began to look at this issue again by continuing to work on the problem of leaving hospital against medical advice. I'm sure most of you are familiar with the Dr. Peter Center. It's an HIV/AIDS integrated health program. It includes 3 core programs, including a day health program, a 24-hour specialized nursing care residence, as well as enhanced supported housing. There's a focus on interdisciplinary care as well as a harm reduction focus. One aspect of that is the operation of this harm reduction room where people can inject drugs under the supervision of nurses. And notably, I'm sure as most of you know as well, Dr. Peter Center is located across the street from St. Paul's Hospital. So we started to wonder, well, does the availability of these types of harm reduction programs in very close proximity to the hospital have any impact on rates of people leaving hospital against medical advice? And again, we found that Dr. Peter Center participants were 58% less likely to leave hospital against medical advice, pointing to, I think, the important role that integrating this type of harm reduction program can play in reducing this very serious problem of leaving hospital against medical advice. We also recently looked at how people felt about accessing an in-hospital supervised injection facility. In this study, we found that 68% of people who use drugs were willing to access an in-hospital supervised injecting facility. And interestingly, though, that this willingness was positively associated with very high-frequency heroin injection, and also people who said they used drugs in hospital were also more likely to report a willingness to use such a facility. Another issue that's certainly getting a lot of attention is the issues of untreated mental health and addiction. And I pose this question as mental health and addiction, or mental health or addiction. And I think this is something we need to seriously attend to. Many of you are probably familiar with the recent reports produced by the Vancouver police calling a mental health crisis or a mental health emergency. And certainly while I would agree that there are unmet mental health needs, we do have some concerns about this type of characterization. In particular, the fact that many of the recommendations stemming from these reports are entirely inconsistent with the recommendations of the Mental Health Commission of Canada. Calls for the reinstitutionalization of people living with mental illness, increases in secure use, secure units are very much inconsistent with the Mental Health Commission recommendations for community-based, peer-based programs and lesser integration of policing in the delivery of mental health services. But if we're going to talk about mental health crisis, I think we also have to look at what's going on in our hospital. And what this slide shows you is that the greatest increase in regional visits to hospital for St. Paul's is actually substance use. There's been an 89% increase in presentations to hospital for substance use, and this is far, far greater than the increase in presentations for mental health difficulties. It's also important, I believe, to consider the very profound impact that addiction treatment itself can have on the remission of psychiatric symptoms. This slide shows you changes in psychiatric symptom scores from intake to residential treatment and at 1 and 6 month follow-ups. And what you see is a fairly significant decline in psychiatric symptoms, and not just the ones that you would normally expect to improve. There are also significant decreases in symptoms such as paranoid ideation and psychoticism. There is also, I think, a further concern related to what can happen if we widely distribute conventional psychiatric medications to this very vulnerable population, as indicated by this paper, which points to the growing problem of emergency department visits for psychiatric medication adverse events. And this is not something we have not seen in Vancouver, as indicated by this safety alert issued by Vancouver Coastal Health, focused on difficulties related to benzodiazepine medication use for outpatients. And certainly in our cohort, we have seen this problem as well. What this slide shows you is that the probability of remaining HIV negative is significantly lower for individuals who report use of benzodiazepines. But what I think this also points to is the very important opportunity we have to better integrate addiction medicine into primary care. But to do this, we really have to close the gap between science and practice. It's been said that addiction care is unfortunately usually provided by unskilled laypersons, and that most medical professionals who should be providing addiction treatment are not sufficiently diagnosed to train or diagnose or treat it. Yet we do have standards of care as indicated by the American Society of Addiction Medicine, and now it's time to start implementing those standards at a very broad level across levels of care. Another area I'd like to just finish up by focusing on is the opportunities afforded by structural interventions, and this is something that our group is increasingly trying to do. We've spent a lot of time observing and reporting on the difficulties that people experience in the downtown east side, and now there's a great desire to try and intervene. And what we've learned over time is that we really miss great opportunities if we focus strictly on the individual and their individual behaviors and health, and that really the health of people who use illicit drugs is very much shaped by a whole host of structural, social, and environmental conditions operating within their broader risk environment. So the question becomes, how can we intervene at the structural level? One structural intervention that we're rolling out soon is focused on alternative income assistance opportunities. It's been well established now through a variety of peer-reviewed studies that drug-related harm greatly increases around check issue day. We see spikes in high-risk drug and alcohol use. We see spikes in people leaving hospital against medical advice, increases in drug-related emergency department admissions. We see spikes in fatal and non-fatal overdose, and we also see interruptions in addiction and HIV treatment. So under the leadership of Lindsay Richardson, professor in sociology at UBC, we're rolling out the TASA study, which seeks to evaluate the impact of alternative check issue on drug-related harm. And simply, this is a three-arm study where people will be randomized after volunteering to participate in this study to either receive their checks on the same check issue day as usual, or to receive them once a month but at a different time. And then in a third arm, people will receive their checks twice a month, again on different days than when checks are traditionally issued. We'll be looking at a variety of outcomes related to risk behavior and participation in health services and other clinical outcomes. We're also have developed a lot of work over the years focused on the income generating activities of people who use drugs. It's well known that in order to finance people's drug habits, people resort to very high risk income generating activities that carry risk for violence and other harms, such as drug dealing and sex work. And this has led us to call for a new arena of research and intervention focused on employment. We recently published a study looking at people's interest in obtaining low threshold employment. And what we found was that a significant proportion of people said that they were willing to give up their high-risk income generating activities if they had an opportunity to participate in other low threshold employment opportunities. So that led us to develop this structural intervention focused on low threshold employment. And what we're trying to do here is really increase access to low threshold jobs. The intervention is very simple. It's a digital clearinghouse of task-based work that people who use drugs can undertake according to their capacity, their availability, and preference. So they can structure it around periods of active drug use as well as medical appointments, and it's very much modeled after existing types of clearinghouses such as the Amazon Mechanical Turk database or the TaskRabbit. And again, we'll be looking at a variety of outcomes such as sustained employment, high-risk income-generating activities, drug use and related risks, and a variety of clinical outcomes. However, if we're going to talk about intervening at the structural level for people who use drugs, I think it would be remiss to not point to the opportunity to improve health by exploring alternative regulatory frameworks for illicit drugs. We know that the criminalization of people who use illicit drugs results in all kinds of harms. Incarceration has been associated with both incidence of HIV infection as well as HIV treatment discontinuation and lower probability of suppression of HIV viral load. But really, while we could be talking about alternative regulatory frameworks for a whole variety of drugs, I think there's some low-hanging fruit, and that pertains to cannabis regulation. Certainly, there's been growing concerns throughout the province about the escalation in gang wars, including recently with over 25 shootings in Surrey alone. And this has led to various health officials saying that the enforcement approach isn't working, violence is rising, and we're also continuing to incarcerate nonviolent drug offenders for the simple use of cannabis. But also, there could be some very important unexpected benefits associated with increasing access to cannabis and looking at alternative regulatory frameworks. This is an interesting paper recently published in JAMA Internal Medicine that compared deaths to overdose associated with opioids in states that have medicinal cannabis laws and those that don't. And what it found was that medicinal cannabis laws were associated with a 25% lower annual rate of opioid analgesic overdose deaths. And this reduction actually got greater as time went on from the point at which these regulations were implemented. Certainly this is ecological data. It needs more investigation, but certainly some food for thought. But also it seems that British Columbians are ready for some change. This is data from an Angus Reid poll in which 75% of British Columbians said that they felt that chasing and arresting marijuana producers and sellers is ineffective and that we would be better off taxing and regulating the adult use of marijuana. So in conclusion, I would just like to highlight that we have made very significant progress in reducing HIV infection and optimizing HIV treatment outcomes among people who use drugs, and that's something that certainly should be celebrated. However, there are now some new challenges, including the problem of undertreated pain and addiction in the population, and if we turn our attention to these issues, I think we can make further progress. I think there's a clear need to integrate evidence-based harm reduction in addiction treatment programs in hospitals. We need to start talking about the principal equivalence, not just in relation to prisons, but also in relations to our hospitals. And doing so may help us address this very important problem of leaving hospital against medical advice, against illicit drug use in hospital, and the undertreatment of pain. While we have made considerable successes by providing individually tailored medical care, we can also build significantly on our progress to date by turning our attention towards structural interventions, including those that really address the very powerful impact that socioeconomic marginalization has on the health of people who use drugs. And in doing so, we should not forget that there's also great potential impact that could be garnered from exploring alternative regulatory approaches to illicit drugs. These not only have the potential to significantly reduce drug-related harm, costs associated with enforcement and incarceration, but they could also have potential to generate funded for much-needed health programs. I'd like to just conclude by acknowledging the many people who take the time to participate in the VIDUS Access and ARISE studies. We wouldn't be able to do this work without their kind and generous participation. As well, the staff at the BC Centre for Excellence in HIV and AIDS and the Urban Health Research Initiative, and as well as our current and past funders, in particular the U.S. National Institutes of Drug Abuse and the Canadian Institutes for Health Research. Thank you.